Okay, well, thanks everyone for joining us for our first discussion in diagnosis. This is a first of a series of weekly meetings we're going to hold at 7:30. We went back and forth about the time, so thanks for joining us, especially for those people like Tony who's up especially early. And I know we have a number of people from the United Kingdom who are going to join, so it's the middle of their day, so I don't know if they're able to join or not. But nevertheless, thank you for joining. Let me just share my screen to begin with. There we go. Okay, so I want to, this particular presentation is mostly just an overview of what we hope to accomplish in these discussions. And the main goal is to keep the issue of improving diagnosis front and center. And this is an official activity of our UH Advanced Center. Advanced stands for Advancing Diagnosis Through Validated Diagnostics and Novel Collaborations for Excellence. I'm the director of the Advanced Center, and we'll talk a little bit more about the center in a moment. So you've probably already heard about the problem of missed diagnosis, delayed diagnosis, which has been declared a public health emergency, according to a National Academy of Medicine report from a few years ago. About 12 million American adults are affected by diagnostic errors annually, just in ambulatory settings. And in 2006, which is quite some time ago, it was found in a review of malpractice cases and quality problems that 59% of diagnostic errors were associated with serious harm, 30% with death. It's the number one reason for malpractice claims. Among the problems that are the most vexing, I think, diagnostically, and this applies across specialties. And actually, if you look at, and I see we have Bobby Hughes on from emergency medicine and perhaps some others as well, abdominal pain is number one. And in my own experience as a primary care physician, I know that that's probably one of the most challenging complaints to evaluate. So undifferentiated, vague, or non-specific symptoms, which haven't yet manifested into identifiable illnesses, including abdominal pain, dizziness, fatigue, fever without an obvious source, in children especially, are especially challenging. And despite the prevalence of these problems, despite how serious they are, the guidance that we have is often of poor quality. This is just one example. There's many examples of this. I mean, the classic example that I didn't want to cite was the evaluation of fever in infants under 36 months of age, because the guideline was so old. But we won't get into that example. Here's another example I found recently. These are the guidelines for evaluation of dyspepsia in adults. Prompt endoscopy is recommended for patients at the threshold age of 60 to identify malignancy. But there is virtually no evidence to back up that particular recommendation. It's just a consensus statements. The other thing I think that we have to keep in mind as the center develops and as we engage in our activities is that best practices do not constitute just accuracy of specific tests, but accuracy in combination with timeliness. Anyone can make a diagnosis if a patient gets sick enough, right? And this is often why in primary care, when we refer a patient to a specialist, they see the diagnosis as obvious because it has had time to evolve into an identifiable illness. And also the efficiency, in other words, resource use. You know, if you did a whole body MRI on a lot of people, of course, you would probably arrive at a diagnosis that's legitimate. And of course, most importantly these days, we have to engage the patient in the diagnostic process. So the need is significant in terms of improving diagnosis overall. There's a need for new diagnostic tools, tests, and procedures. But our center, the Advanced Center, is going to be focused upon identifying best practices for diagnosis. This quote is now almost 35 years old, comes from G.T. Levitt at the University of Southampton. And he talks about in medical school, and this is true around the world. If you look at any textbook of internal medicine, for example, it's often organized by system and illness. And that's how I learned about illness as well. You know, you flip on flip to the page on sarcoidosis, and it gives you a list of features. And hopefully, if you saw a patient with sarcoidosis, you could make that diagnosis. But that's not how real life works, of course. And this applies not just to general practice, but to other disciplines as well. Undifferentiated illness is the bulk of a general practice caseload. It's difficult to define, and approaching undifferentiated illness in a rational way it should be a priority in training, and it is a priority for the center as well. So I mentioned the three goals of any particular diagnostic approach: it's accuracy, timeliness, and resource use. So let's talk about the Advanced Center. We just got our notice of award about 5 or 6 weeks ago, and it's from the Agency for Healthcare Research and Quality. I'm the PI. Dr. Miller, who is on the call today, is my co-PI, along with Dr. Pronovost and Mary Delansky, who's also on the call today. And I'm very proud to have Mary especially on, because she's from the School of Nursing. And Mary and I had many discussions prior to this that nurses are partners in diagnosis, and there's a significant amount of literature and policy statements that support that. The mission of our center is to identify best practices for diagnostic evaluation of common conditions that are associated with diagnostic error. The classic examples are dizziness, undifferentiated abdominal pain, sepsis, hypertension in children, and what we'll talk about next week, unintentional weight loss. So we'll employ a 4-step strategy. I won't get into too many details, but the first step is to look at what evidence is out there to support a specific diagnostic approach. Then we will engage in a data-driven approach to identify current practices and their outcomes. So for example, Dr. Macias and Goldstein are looking at sepsis in children and adults respectively, and they already have a sepsis protocol. And they can look at and they can refine the protocol based on what is actually happening in our health system. And once that's done, we can start to draft some best practices in terms of diagnostic approach. And these will be presented to a panel of diagnosticians led by Dr. Jessica Goldstein. And then after they have formulated their recommendations, they'll be presented to our center advisory board for its approval. And the final step is to actually evaluate its impact on practice and the outcomes associated with it. So that approach, of course, has been developed, refined, and thought about by somebody, myself or other members of the team that I've worked with for many years now. The advisory committee, the diagnosticians panel, this is out of date. We have well over 30 clinicians from different disciplines. We're also a focal point for improving diagnosis nationwide. There are only 10 of these centers in the country that are funded, and we are in very distinguished company. 3 of the centers are in the Harvard system, including one at Boston Children's. There's one at Johns Hopkins and at MedStar. They're not evenly distributed across the country. 2 in Houston at Baylor and at UT Houston, UCSF, and Oregon, as well as us. So very distinguished company indeed. And it's going to be a central component of health services research efforts here at university hospitals. And the budget, of course, is significant. So what about these particular discussions? Well, I'm hoping this will be the last PowerPoint slide you'll see at 7:30 on Friday morning, but I can't discourage people from using PowerPoint slides or not. But what I want to do is to make this a series of conversations about interesting topics in the broad domain of improving diagnosis. So I'll serve as the host. And of course, our speakers will have questions that will be posed to them, which they will respond to based on their experience. And of course, I'll get the questions in advance. But these topics can be included within the categories of diagnostic research methodology, which can be quite sophisticated, understanding diagnostic tests, which I think will be especially helpful for our residents, even basic things such as test characteristics, C-scores, likelihood ratios, et cetera. Things that some of us have taught for many years. And clinical topics in diagnosis, of course, are going to be a major focus of the discussions as well. We'll have a question and answer format. We do have a YouTube channel. This particular talk will not be on the YouTube channel. I know some of you have already subscribed, but my technological skills have failed me at some point. I'm not able to log back into the channel. So I will post this at a later date for you to look at. This is a quote from Jerry Kasserer, and I think I raised this quote because some people wonder: is improving diagnosis a distinct domain to which we can all devote our efforts? Isn't every particular patient, every particular illness, every particular discipline so unique that, it's difficult to identify best practices. But I think Jerry Kasper has a very nice approach to it. I mean, first of all, he states that absolute certainty in diagnosis is unattainable, no matter how much information we gather, how many observations we make, or how many tests we perform. The diagnosis is a hypothesis about the nature's illness. And what we can do, essentially, our task is not to attain certainty, but rather to reduce the level of diagnostic uncertainty enough to make optimal therapeutic decisions in which we have some degree of confidence. That's the purpose of the diagnostic process. That's the purpose of the Advanced Center, to reduce diagnostic uncertainty, not to identify the absolute 100% accurate approach to diagnosis for every problem, but to give us the confidence as diagnosticians and as clinicians to reduce our own uncertainty so that we can make decisions about treatment. So here's an example. And the other thing that comes up is, are there examples of diagnosis actually improving significantly? I pointed out to you that guidance is extremely scarce, and it's often of poor quality, and that undifferentiated problems are pretty much managed the same way now that they were 25, 30 years ago. We do have some better imaging, for example, for certain types of problems, but we're stuck in some ways. How do we improve diagnosis? Well, the good news is there are examples of diagnosis improving significantly. Consider the Ottawa ankle rules. You probably heard about these. I certainly heard a lot about them in medical school. These were finalized in 1995. And, they are helpful in a way, of course, 27 years later, I don't know. And some of our emergency medicine colleagues could probably comment on these. How useful and how applicable they are is a little questionable. But the goal was to order imaging studies more judiciously among people with ankle sprains and to avoid unnecessary x-rays. Prior to their widespread implementations, x-rays were ordered on 98% of patients presenting with ankle sprains in emergency departments. That's just about everybody. X-rays are not terribly expensive compared to many of the diagnostic interventions that we carry out in the emergency room setting, but boy, can they disrupt flow, not just for nurses and other clinicians and x-ray techs, et cetera, in the emergency department, but also for patients. If you're waiting for your x-ray, that can be disruptive as well. And if there's a way to reduce the number of these x-rays, that would be a useful intervention. So the ankle rules can help systems avoid up to 40% of plain films for ankle sprains. These are the ankle rules. And again, this is not going to be one of our first clinical diagnostic talks, but the rules are fairly simple. If you have tenderness at the tip of the lateral malleolus, the tip of the fibula, or of the tibia, and inability to bear weight, you should get an ankle x-ray. And of course, there are two locations for foot x-rays, which should be ordered simultaneously as well. So these are fairly basic. I learned about these and applied these in urgent care and emergency room settings a long time ago. And of course, this is diagnostic guidance. It doesn't really, there's other things to take into mind. I told you that accuracy, timeliness are some of the features of a good diagnostic practice, but there's also the patient involved. And of course, some patients insist on an x-ray to rule out fracture. And some patients don't want it. They may not be able to bear weight, which is defined as taking 4 steps, but they may say, I've got to run. I'm going to take care of this at some other point. So those are factors that we can't account for. The usefulness of these particular rules has been demonstrated over and over again. This is from a meta-analysis. So they're highly sensitive. They will pick up most fractures, but they're not terribly specific, which accounts for why they reduce the number of x-rays if they're applied properly by a significant portion, but still you would be doing a lot of x-rays. The negative likelihood ratio is how often a fracture occurs among people with a negative Ottawa ankle rule versus a positive one. And as you can see, it's very low. So you're not going to miss too many fractures. So I want to stop there. And this overview, I think, was to give you an idea of what our mission is. We're going to get into the nitty-gritty of conversations beginning next week. Dr. Kelsey Ufholz has agreed to speak to us about unintentional weight loss, which is one of our demonstration projects. And I want to shout out to Dr. Jordan Winter, whom I do not see. on the call today, but Jordan is the head of surgical oncology and turned me on to the nature of this problem that unintentional weight loss, especially in older patients, is often a sign of malignancy. And because older patients are less likely to be conscious of their weight and weight changes, it's an early sign that's very easy for us to evaluate and detect. And Kelsey will be speaking a little bit about that next week. So let me stop and see if we have any questions at all about the center or our mission or these discussions.
Hey, Dr. Rao, it's Bobby Hughes. First of all,
Hey,
it is an absolute it's an absolute pleasure to be a part of this group. I'm really excited. Dealing in uncertainty is, part and parcel with what we do in the emergency department, but I think in medicine, period. One of the things that I think would be a unique benefit of this, sort of going back to the discussion on X-ray and diagnostic utilization, is a lot of incentivization of medicine is based off a customer service model. And so patients now sort of transitioning into partners in healthcare and customers and the pursuing of value in healthcare overall leads to a lot of potential conflict with diagnostic strategies versus patients' expectations. And what we found success with in the past is widely adopted and fully accepted guidelines sort of put to patients as a part of that partnership so they understand both the medicine of what's happening as well as the attempt to try and meet them where they are. The PERC rule in emergency medicine for pulmonary embolism is a really good example of something you can sit down and have a discussion with the patient about why a CT may or may not be indicated for pulmonary embolism in the chest. But I think that navigating those waters, especially as we move forward into models that have compensation built up against patient satisfaction scores and the like, is going to be really important. So the broader adoption of stuff like this is going to be super helpful, I think, in actually furthering that partnership.
Yeah, thanks for those great comments, Bobby. So our stakeholder panel includes patients as well, and their perspective. And what you said it resonates with me a great deal. So I deal a lot with childhood obesity, as most of you know, and cardiovascular risks, and run an ECHO program at the University of Chicago for that purpose. And the example we were talking about the other day was the parent who comes in and says, "I'm convinced that my child has a syndromic cause of obesity." Usually they think it's the hypothyroidism, or if it's not, it's something more complicated. And you've got to find it, basically. And how do you explain that to a patient? How do you do it? And the partnership model that you described, I think, is critical in the sense, and you don't say, "Well, that's ridiculous. We're not going to order all these fancy, expensive tests." What you say is, "Well, I understand you're very concerned about this, and you obviously care about your child a great deal. Here's what I can do. I'm going to do a thorough physical exam. I'm going to order a limited number of tests, and let's make a deal. If those come back as negative, we will work on a different approach altogether." So I think that sort of partnership between patient and clinician is increasingly important. So thanks.
And can I also, Goutham, can I also just add that where the nurse kind of intersects there is the nurse can also create education materials for patients on, the proper, I guess, assessments and diagnostic procedures, can reinforce the messages from the physician, and kind of work in partnership as a trio on that.
Terrific. Yes, absolutely. Any additional comments or questions? Brian, you unmuted. I'm sorry.
Yeah, good morning. Just again, to reiterate Bobby's comments, such a pleasure to be here in this company and part of this process. I think from the primary care pediatric perspective, the only two comments I wanted to make is not only are these efforts so important, but actually socialization of the efforts down to the level of the primary care and specialty providers who get into the routine of our day-to-day work. And it doesn't actually strike them that there might be new information that might guide us. And so not only creating obviously good studies and making them available, but socializing them in a positive momentum direction is going to be so important so that we know to look for them. And then also wearing one of my other hats, just to throw it out there, virtual care is here to stay. And in many different capacities that might evolve as the public health emergency ends in the coming 12 months. But so many providers are providing some of this frontline triage and initial touches with their patients virtually, that considering that as part of our workflows might be of consideration.
Yeah, terrific, Brian. Thank you. I think we have, especially, I know this is a center that we've invited people from many different institutions this morning, but we are, as most of you know, undergoing a transition to Epic. I think we're the last major academic health system to embrace Epic. So it gives us a lot of opportunities. And my dream, and Kelsey and I have talked about this a little bit, is an alert in Epic that says, do you realize your 85-year-old patient has lost 16 pounds in the last 3 months? And well, maybe you ought to have a conversation with him or her about this. That simple tool is not there, and that's a great form of socialization. We can start to raise awareness of the problem as well. Thanks, Brian. Any additional comments?
Hey, Goutham, this is Marlene. Can you hear me?
Yes, I can. Go ahead.
Hey, you've been implying it, and I just want to really call out, we just actually finished a big project on a subterm in here of diagnostic stewardship, which is almost the opposite end, which you've been obviously talking about, but just labeling it, which is not overly testing, right? We just finished a big project that multi-center that got published in JAMA Peds on, trying to decrease the use of blood cultures in ICUs because it's such a inherent, you almost want to rule out everything, but there's so many times when you don't necessarily need another blood culture, but yet you don't want to have, you also want to have balancing measures that you're not then increasing sepsis deaths or something like that along the line. So I would just want to call that out because I think we have both, like, what is the right diagnostic test? And then at the same time in stewardship, what's too much diagnostic testing, right? Everybody doesn't need a CBC every day, right? Kind of thing. So I think this is just so important on both ends of that kind of spectrum.
Yes, no, absolutely. Thank you. Any additional comments? I looked at the chat for a second. Okay.
I was just curious if part of the excellence in diagnosis would include some screenings as well, and if we think that and the other questions really is that if this would be the main project or you are open to more projects, and how would be the approach to a new project that can be applied to figure out excellence in diagnosis in a different area.
Yeah, this is a great question, Tamer. Thanks. So this is, I think the center and our funding is just the beginning. We've been funded for 4 years, and there are 3 large demonstration projects. One is to identify best practices for unintentional weight loss. Second one, near and dear to my heart, is best practices for diagnosis of hypertension in adolescents in out-of-office settings. And the third one, which Charles and Jessica are involved in, deals with sepsis as well. And we selected these projects because we have the expertise and interest in those. But one of the principal aims of the center is to explore other areas, other topics, and other problems that are that are challenging in terms of diagnosis, and actually become the focus center among the 10 centers nationwide because of our approach to best practices. So perhaps at MedStar or at Baylor, they have another problem that they're especially concerned about. And we could say, well, this is how we approach it. We can help you determine best practices within your institution. We did establish, and I think I wrote about this a few years ago, and Tony, I think you were probably on the paper. What are the sorts of problems that we want to tackle? First of all, they have to be relatively common. So that seems obvious. The underlying condition that we are trying to diagnose has to be associated with a symptom complex that encompasses both serious and benign problems. So abdominal pain is the classic example in the emergency room. It can be nothing. It can be indigestion. It can be benign functional dyspepsia, or it could be gastric cancer. If it's always associated with a benign condition, it's not really a high priority for our center. And if it's always associated with a serious condition, it's different when someone has lost 10 pounds unintentionally, but if they've lost 50 pounds, you're going to investigate and monitor that patient carefully. That's not necessarily our focus as well. So, and the third criterion is there has to be variability in how we approach the problem. So back in Chicago in, I don't know, 2011 or 2012, I met with a group of internists and family physicians, and I said, 35-year-old man with abdominal pain, perfectly healthy, has no other health conditions, comes to see you for his abdominal pain, has no tenderness, nothing on exam. How would you approach this particular patient? And the answers were all over the map, from ultrasounds to let's give them a proton pump inhibitor and see what happens, to, you know, just watchful waiting, to over-the-counter antacids. There was no consistency in how people would approach it. So that tells you right then and there that this is a problem that is ideal to try to develop some guidance around. So the short answer to your question, Tom, is yes, we are open to other problems. We need to get started with these first, and then we'll move forward. Now, I know that we have not actually met as a research team. For those of you who are on the research team, we are waiting to hire our research manager. It is a complicated process because she's based at Case, but I promise you we'll start to have more meetings and talk about screening and other things soon enough. Okay, any final thoughts before we wrap up this morning?
Hey, Goutham, just on that point, and
Yeah.
I'm sorry I couldn't see your slide because I'm in the car. It would be really nice just to make sure everybody that's involved here knows exactly what the other projects are, the other 9 centers. Because if we want to do something and say what one of the other centers are, we need to leverage some kind of collaboration across all these grantees if possible.
Yes, absolutely. And so perhaps we can, I can send out the website. I don't know what their specific projects are, Marlene. We just have descriptions of their mission and key activities. Of course, we know Johns Hopkins because David Newman Toker is there, but the other centers I'm not sure of.
The ARC project officer may be able to collect that for you if we ask, right? You know, even the specific games, just so we know, so we're not duplicative and we can synergize if it makes sense.
Absolutely. And he was actually going to be on this morning, but I don't see him here. Dr. Rao. Okay. All right. Any final thoughts? Okay, well, thank you all for joining me this morning. Our first real conversation is going to be next week, and Kelsey and I will plan for that. After that, we are going to take a 1-week break, and then I believe we're starting again. And Dr. O'Riordan he was at University of Manchester, but he's on sabbatical in Australia, so he has some time problems, but he has agreed to join us as well. And that'll take us into the new year. So thanks very much, and enjoy the rest of your day and your weekend as well. Bye-bye.
Thank you.
Thank you.